Heart attack, coronary artery disease, and acute coronary syndrome means heart attack. Acute coronary syndrome means you're having a heart attack. So we're going to kind of talk about the two. And one of these things leads to the other. So here are the things I kind of want you to know about it. I'll let you read through those. Coronary artery disease just means you got plaque. You got plaque in your coronary arteries. Guess what coronary artery disease in your legs is called? Peripheral vascular disease. Oh, because it can't be called coronary artery disease if it's in your legs. It's not your coronary arteries. It's in your leg arteries, so they call it peripheral vascular disease. Same thing. It's all atherosclerosis, which is a hard word to say. That just means you've got fat deposits. These fat deposits are not hard themselves. They're fat, but they get lumped down onto the vessel wall, and they're lumping to tears in the vessel wall. So your vessel wall gets torn. Why does your vessel wall get torn? Because it's weak. It's under a lot of pressure. It's got tobacco use thinning it out. You got a lot of stuff going on. Diabetes is weakening it up. You got some infections. Anyway, the vessel wall tears and fat just kind of gloms onto it. So as fat gloms onto it, then the white blood cells are like, wait, we need to fix some things up. It turns into scar tissue. It turns into like this big mass of the white blood cells start like, what's going on here? Let me clean this up. And then as they clean it up, they end up creating scar tissue over it and all this, and it becomes like this big hard lump. It's like a speed bump in your vessel. So blood's flowing by this nonstop while, there's construction going on and trying to clean it up. And it can't really just fix the vessel wall if there's fats all around it. So it's like, you know what? I'm just going to pave over it. I'm going to pave over it with scar tissue, and we'll just make it, a speed bump. Yay, now you have a speed bump. But as this speed bump keeps getting things ripped and torn and on top of it, it's like, okay, let me pave over it again. Okay, let me pave over it again. And now you're ending up with like this huge speed bump in your vessel. And blood can't get by a giant speed bump in your vessel. So you end up getting blockages. Because all it takes is one little clot, which normally would pass through, no problem. Then it gets hung up. So that's atherosclerosis. I can't really say it very well. Or hardening of the arteries. That's what's happening, is that basically you're tearing your vessel wall, and the repair process decides, I can't fix it. There's too much junk on top of it. I'm just going to pave over it. And that's what atherosclerosis turns into. And that's why if that's happening all around your artery, all throughout your artery, you get a lot of speed bumps. It's like one of those roads where they put speed bumps every 3 feet. It's going to take you a long time to get through that because it's a pain in the butt. So as these speed bumps grow, vessels kind of grow around it. Because, if this highway is going to be under construction or have speed bumps, are you going to take that road? No, you're going to start taking other roads. Because that road is a pain in the butt, and it takes forever to get through, and nobody likes the speed bumps. It messes up the transmission on your car, so you're going to start taking other roads. So we actually start building other roads around it. Yeah.
Before we go any further, so atherosclerosis is an umbrella.
It's a big word.
But then coronary artery disease and peripheral vascular disease are kind of subtypes of that?
Atherosclerosis, describing where the atherosclerosis is. So atherosclerosis just means plaque buildup in your vessels. Coronary artery disease means it's plaque buildup in your vessels of your coronary arteries. If you have peripheral vascular disease, you have plaque buildup in your peripheral vascular system, which means outside. So atherosclerosis is plaque buildup. So vocabulary, medicine. You're learning Medicine 101. This is vocabulary lesson. Atherosclerosis means plaque buildup. And where it is what kind of disease it is. So atherosclerotic disease of the coronary arteries, coronary artery disease, atherosclerotic disease, or atherosclerosis of your peripheral vascular is peripheral vascular disease. So no matter where it is, whether it's in your coronary artery or peripheral vascular, as these things build up over time, you have a lot of collaterals. These extra branches grow to get blood around the blockage. So if it happens slowly over time, we build up a lot of collateral circulation, which can carry us through when things get blocked completely. We've got side roads built. So we have some certain, it's not efficient, but it is a way around. So it's, even though that people are like, how could you be living with 99% occlusion of a coronary vessel? Because you got a lot of collaterals. That's how you're living. You're living your life through side roads because the main road is like 100% blocked. You can still get around, it's just not very efficient.
So that pressure is still hitting up against that blockage, which can cause that breaking off, though.
Actually, the problem that we're not really having isn't that plaque breaking off. We're having is signs and symptoms of blood not getting past that plaque. So, the side vessels, if we have them, are great, but they're smaller. They're much easier occluded as well, and those are risk of damage too. Those itty bitty vessels can get damaged and torn, and you can have plaque build up in those little itty bitty vessels. So really, when we see symptoms, we're seeing almost the end of this. We're seeing like everything's blocked up.
So like if the surgeon went in to clean out the plaque, would they cut off the extra pieces on the side?
No,
They leave them?
they leave them. Oh yeah, you built them, you get to keep them. If you build them, you keep them. No, they don't remove them. They will just go through and clean out the plaque and see if we can get more blood flow through, but no. Hey, look at that, same slide. Risk factors for coronary disease or any kind of atherosclerosis, same thing. Okay. This one, I'm just going to go into a little more detail on the lipids because, of course, this is also peripheral vascular. You're going to see it again in peripheral vascular disease. But for coronary artery disease, our big problem is that rather than ripping a vessel and then just being able to go in and fix it, we rip a vessel and now there's so much fat or cholesterol in our system that it just kind of gloms onto that. And then we can't really fix it. We just pave over it. So the more cholesterol that we have running around in our system, the more risk we have of building up these plaque vessels. So if your cholesterol is greater than 200, or your bad cholesterol, your low density ones are greater than 100, you are at higher risk for atherosclerosis or so you think if you have these cholesterol levels, you're not only at risk for coronary artery disease, you're at risk for peripheral vascular disease as well. Not just one or the other, it's all of it. So if you have any of these lab values, you're just increased risk. So that just basically defines more what this means. Okay, so that is the same slide as this. It's just the lab values that mean elevated lipids is these things. Cholesterol greater than 200, bad cholesterol greater than 100, and good cholesterol lower. So we want a lot of our good cholesterol. That, if you want to think about it simply, the good cholesterol doesn't get hung up on things. The bad cholesterol does get hung up on things. And if you have a high total cholesterol, your chances of having more bad ones are good. If you have a cholesterol of 280, but it's all high density, that'd be okay. But most people don't. If you have a high total cholesterol, it's probably a high amount of the bad ones. So anyway, what do we do to reduce this? Since this is a modifiable risk factor, we didn't talk much about it in hypertension. We talked mostly about just vessel constriction and dilation in hypertension. You can see all of these end up going together. If you have hypertension, you're probably going to have high cholesterol too, and you might be on both. But the statins are meds that decrease your cholesterol level. And if we decrease our cholesterol level and we don't have as much circulating around to get torn up, hung up on those tears, then maybe we can just fix those tears without them becoming speed bumps. So we try to reduce our cholesterol level if they have high cholesterols. So these are statins. Hey, guess what? Their last name is Statin. That's really nice. I love when they name things nice like that. So anything with a statin on the end of it is an anti-cholesterol med. A cholesterol lipid lowering means lowering cholesterol, anti-cholesterol, whatever you want to call them, lipid lowering, anti-cholesterol. Statins, all the same thing, and they will decrease the amount of cholesterol in the hopes of decreasing the speed bump formation in your vessels. There are a couple of other things. Statins are the mainstay. There are a couple of other things that you can try. I know my husband got to try niacin, which he denied right away. Niacin is a B vitamin. And it does show that you could take niacin, this B vitamin, to help decrease your cholesterol levels. But it causes a lot of flushing and vasodilation. And he was like, heck no, I don't like that one, and stopped taking it. So he's on a statin. I'm going to use him as an example because he's the what not to do person. They also have some other things, this Zetia and whatever, but really what I want you to remember is statins for cholesterol. Most patients are on statins unless they've said, no, I'm not going to take a statin. Most patients are on statins. That is the mainstay of treatment for getting rid of cholesterol. So we've talked about cholesterol. That's our modifiable risk factor. It's just a little bit extra, you know. I didn't want to throw all the meds at you at once. I throw them to you in little bits. So let's go to the heart now. We're going to talk about this atherosclerosis in our heart. We have it. They may be on statins, they may not. They have atherosclerosis of their heart. How do we know? How do you know that you have coronary artery disease or atherosclerosis of your heart?
Do they do the ultrasound?
Yeah, you have no idea that you do until you're starting to have chest pain. When you're starting to have chest pain, it's way advanced. Unless you happen to catch it on some kind of screening test or something, you have no idea you have coronary artery disease. We can all have coronary artery disease right now and not know it. Unless they took a cholesterol level and guessed that you have coronary disease. How do you see the coronary arteries? What's the only way to see the coronary arteries?
A nuclear imager.
Yeah,
Stress test?
you've got to do a scan. A stress test only shows you how your heart reacts to stress. It doesn't tell you anything about your arteries. The only way to physically see your arteries is to scan and possibly look at blood flow around the heart, or go to the cath lab where they put the thing in your leg and they put a camera into your coronary arteries. There's no good way to see into your arteries. It's not invasive and expensive. So we just kind of assume that if you have a high cholesterol, you're probably at risk for this and you're probably going to have it. But the only way to really know that you have it is you're starting to have chest pain. Because the blockages have gotten so big that it's cutting off blood flow to your heart. So heart disease is just the actual atherosclerosis. Angina is temporary. Angina means that it goes away. Except that we have a whole lot of different words. Angina means heart pain. Pain of your heart. You can have angina for a lot of different reasons. Not all of them are coronary artery disease. Angina means heart pain. So when you're starting to have heart pain that goes away, we know we're getting kind of, you got a blockage that's getting a little tight. When you have heart pain that doesn't go away, we call it a heart attack. It's all angina. Angina means heart pain. Angina that goes away, okay. Angina that does not go away, not okay. So, angina and heart attack can be used together. It's angina that doesn't go away is a heart attack. So, chest pain. Why do you have chest pain? Well, your heart needs oxygen to keep beating, right? It has a hard job to do. It gets no thanks for it. Does it all day long. But it needs oxygen to do that. So when those coronary arteries, these are blood vessels on the outside of your heart. When the blood vessels on the outside of your heart get blocked, there are pieces of your heart muscle that get blocked. And let me find, I need do I have a rubber band somewhere? You may have a rubber band. I'm going to do a demo that I do for all of my heart patients. I'll take that. Okay. So, heart pain is, you can do this at home for your kids. I do this for all of my heart attack patients. This is a visualization of angina, okay, the best one that I can come up with. What is happening to my fingertip? There's not blood flow going to that because I tightened it down because I'm an idiot. I'm going to release it. But this is what is happening to your heart. This is your heart blocked up, okay? This is happening to your heart muscle. If you cut off blood flow to your hand, this is starting to throb and hurt. That's starting to throb and hurt. I should probably release that at some point. But this is it 100% blocked? No, but it's pretty close to blocked. I may have enough viable blood getting through here to keep it from dying all the way, but this hurts. This hurts. So now I'm going to sit down and stop stressing myself out. I don't need as much oxygen. So now I've released a little bit. Oh, that doesn't hurt anymore. Okay. That was sore. I probably shouldn't do that again. So if this was in my heart, we would call that angina. I'm just going to call it pain, finger pain. But if it was on the heart, we would call it angina. Okay? So let's say now that this blockage doesn't go away. So hypoxic means it's not getting oxygen. So right now, this is hypoxic. And I can see it's hypoxic because it's turning what? Blue, purple, all kinds of fun colors. It's not getting enough oxygen. It's turning hypoxic. Within 10 seconds, your finger starts turning colors. It's viable for 20 minutes. I could leave it like this for 20 minutes. I wouldn't want to. What would happen to it in that 20 minutes? I'm not going to do this. Sorry, I don't love you guys this much. It will, you won't see the damage. It will start getting red, swollen, sore, and then it will turn white. Okay? So when we are having a heart attack, that is what is happening kind of there. Except that there's no way to open that vessel. Slowing down and sitting down doesn't change anything. Slowing down, sitting down, oh, it didn't release it. Oh my gosh, it still hurts. It's still there. The only way we can go in and release it is to go to the cath lab, go into the coronary arteries and remove that plaque. It's the only way to get blood flow back. So thank you for letting me use you. I will now let my finger come back.
Thank you for listening.
Oh, I'm not going to risk my life. But I could have let my finger go for 20 minutes before it started having damage that was irreversible. And even after 20 minutes, it's still reversible. Because what would happen if you let your finger go bad? Look, now it's turning bright red. Reperfusion injury. What would happen if you let your finger go for 20 minutes and it turned completely white and then you got blood flow back to it? Oh, it would hurt like a mother when you got it back. But also, your fingertip would fall off. But the rest of it would slowly, not the fingertip, but like the fingernail. Like, have you ever crushed your finger? And the fingernail falls off later? It's kind of that thing. But it will come back. You can crush your finger. You can cut off blood flow to it. And it might regenerate, but it won't be as good as it was before. Maybe you'd lose a fingertip. Maybe you'd lose your fingernail. But the finger wouldn't completely just fall off and go away. So the heart does the same thing. So what we're doing with angina is we are saying this is reversible. But just not angina. This is reversible angina. Reversible angina means that when you stop doing whatever stress you're doing to the heart, it goes away. You pop that little cord and everything's okay. Are you healed?
No.
No, the cord's still there. Whatever's, you got about 20 minutes. If it goes away within 20 minutes, you're okay. But angina is just a lack of oxygen, and this is just why. This is a background. You don't need it. But angina hurts because when you cut off blood supply, it creates, your body still needs to do whatever it's doing, and it's going to create energy another way through lactate. It basically creates lactic acid. If you've ever worked out very hard or run very hard and you work out very hard, you hurt the next day. Why do you hurt the next day? Lactic acid. Because you couldn't supply your muscles with enough oxygen. There's nothing wrong with you. It's just that your muscles were working harder than your intake of oxygen. So they started creating energy another way, which the byproduct of that is lactic acid, and lactic acid hurts. So that's what's happening there is your oxygen's being cut off of your heart. It starts to hurt. It's sending signals, hey, I'm starting to hurt, but that lactic acid production, because your heart's still beating, and it's still got to work, it's just not getting oxygen, so it's creating lactic acid. It starts to hurt. Then that referred pain transmits all to this upper area. We don't have pain fibers to our heart, so things get a little mixed up. It doesn't have direct fiber sensation like our fingers do. So when our organs hurt, they kind of refer to weird places. And the heart refers to the throat, the jaw, the arms, and the back. So you may have pain any of those places if you're having pain in your heart. So anginal pain, meaning that you are cutting off blood flow to your heart. Heart pain feels like a pressure. It's ache, squeezing, heavy, choking. It can be weak. It can be strong. Don't know. There is no one pattern. Everyone has their own pattern for how they feel chest pain. But it's usually in the upper area. Women do not have strong referred pain for angina. Their referred pain is either trouble swallowing, heartburn, or nausea. That's not a very good
It's
sign.
like the worst, like.
I know, isn't that terrible? So, women got the bad end of the deal on that one. So maybe because the men got more risk factor, they got stronger signals. I don't know. But women don't have as strong of signals. That's kind of unfortunate. One lady came in, she was so bad gone that we couldn't even do surgery on her. But her only symptom was that she was short of breath when she walked, and she threw up when she got anxious. And so her family just thought she was dramatic. And they would come in and she would go to a cardiologist, but she had nothing specific. It was all angina. Nothing showed up. And so by the time she had so much damage to her heart that we couldn't, and we're like, that's just terrible, And they're like, yeah, well, she couldn't walk across Walmart. And we're like, that's not good. And whenever she got mad, she would puke. We just thought she was being dramatic. Like, oh, she was having chest pain. You don't know. So I'm not going to tell you that there's a template for chest pain, because there isn't. But this is what they say, it could be anything. So always get it checked out. It's easier to check out and be nothing than. So what we are talking about when we're talking about angina is angina that goes away is considered chronic stable angina. It's stable because it goes away. So if you're having chest pain that goes away, it's called chronic stable angina. If you have chest pain that doesn't go away, you're having unstable angina, meaning it's not going away, and you're having a heart attack. This Prince Metals angina has nothing to do with coronary artery disease. So you may be having chest pain, but it has nothing to do with coronary artery disease. It's triggered by histamine reaction, and it's just vasospasm. It's still chest pain, feels just like chest pain, but then when they go in to do EKGs, it doesn't show anything, and they have to do it to diagnosis of exclusion. But it is angina, it is chest pain, has nothing to do with coronary artery disease. As far as you're concerned, you're worried that they're having angina that goes away or angina that does not go away. So when someone comes to you with chest pain, the first thing we need to do to assess it is what? See if it goes away. Sit them down, have them rest, and see if it goes away. If it does not go away, it is unstable. All right? So let's look at stable angina. This is acute pain, it's anxiety, and they may be having decreased blood flow to the heart, but it's not consistent, it's not long term. So what we're going to do is we're going to sit them down and assess them. While you're assessing them, hopefully their chest pain is going away, right? So if someone walks up to you on the street and says, I'm having chest pain, what are you going to ask them to do?
Sit down.
Sit down and let me look at you, okay? Sit down, let me look at you. Because we need to take a look at them. You need to assess, chest pain could be for any reason, it's heart pain. Could be maybe you just overexerted yourself and too much oxygen, not enough oxygen. I don't know, but we need to have you sit down and be assessed. If you have supplemental oxygen, it's never a bad idea. Whenever your heart is having pain, it doesn't hurt to give it oxygen because it might need some extra oxygen. It's having pain, why? Because it's not getting enough oxygen, so it'll never hurt to give a painful heart oxygen. Sit them down, have them rest, supplemental oxygen, and say, is it still hurting? Because by then, you've gotten it's been a couple minutes, right? Are you still having chest pain? Yes. Is it stable or unstable? Unstable. If you sit them down, assess them, give them oxygen, and they're like, oh, that's better. Is it stable or unstable? It's stable. Even though you don't want to call it unstable, you're like, I don't like that, but it went away with rest, okay? If it does not go away with rest, then we start ramping up our interventions, okay? Nitrates, which is also known as what? Nitroglycerin. If it's going away, they don't need a nitroglycerin. If it's not going away, I don't know, it's still there. Now you've got a nitroglycerin. So you've done an assessment, you have them resting, you've got them oxygen, now you're gonna give them a nitrate, okay? Does it go away with that? Yeah. Is it stable or unstable? Stable. I know, you're like, wait, I just gave them nitroglycerin. But a lot of people have angina and they pop a pill or two and it goes away. They're still considered at home stable, not having a heart attack. It's stable. So, sit down, rest, oxygen if you have it. If you don't, sit down, rest. Is it going away? Yes? Great. Now they need to just go talk to their doctor. No? Then what? Nitrates. Nitrates work? Great. Hey, you got nitrates on you, so you must have the history. Maybe you should let your doctor know you're having more angina or something. Follow up. If no, what should they do? One nitrate. Doesn't work. Take another. Take another. Does that one work? So we kind of step up. So chronic stable means that it goes away with rest or with some of our first interventions, okay? If it's not going away after nitroglycerin, we're having a heart attack, okay? So if it goes away, we're going to call it chronic stable. So it went away with rest, oxygen, or nitrates. We're calling it chronic stable, and they need to make sure that they stop doing whatever was precipitating this, probably exercising. Some people have angina if they cross the room. That's more unstable than someone who only has angina once a year. But it's still not a heart attack until it's happening without rest. So we need to figure out where they are on the scale. Do they need to go to the doctor? I would still, someone who got better with rest, if they came up to me on the street and said, I'm having chest pain, they took their nitrate and it got better, they should still probably go into the ER. Just get checked out a little bit. And they're like, oh, it happens 5 times a day. Why don't you go see the doctor? But what we want to do is make sure that we decrease their demand, which means rest. Give them O2 if we can, okay? If we're on the street, we don't have O2. If we're in the oxygen, if we're in the hospital, we have O2. So we give them O2, and then we give them their nitrates. And what it does is it will dilate blood vessels. It's a direct vasodilator. Remember we talked about it with the hypertensive crisis. This is a little pill version of a direct vasodilator. It works right on the coronary arteries and dilates them out. So it buys you time. So if they are almost completely occluded and we can dilate a little bit, blood flow will go by that blockage. But that's how we know whether the blockage is stable or not. So if it works better with nitrates, then they probably need to go to the hospital. Or they don't need to go right away, but they'll need to get there. So if no pain relief in 5 minutes. So what we're doing with the nitrates is 5 minutes apart. Okay? So you're not going to leave this patient. You're going to stay with them. You're going to sit them down and rest. Give them oxygen, or not if you don't have it. Give them their nitrate. Did the pain go away? No. How long do you wait for the next one? 5 minutes. Are you going to wait 5 minutes? Or are you going to call EMS? If your patient is having chest pain that is not relieved, if you are out in the world and somebody is taking a nitrate or doesn't have nitrates, just straight to EMS, okay? If they're taking a nitrate and it's not getting better with that first nitrate, EMS. If it gets better with the first nitrate, hey, why don't you get to the ER? Just to double check. If they don't, call EMS. Call EMS after that first one. Okay? Any EMS in the room? Are y'all mad at me now? That we called EMS after one nitrate?
We're going to give it to them anyway.
Yeah. So call EMS because you don't know if it's going to be stable or unstable at this point. You're headed to nitrates. Get EMS involved. If this is your patient in a hospital bed, you would go, hopefully they have nitrates that you can get to. If not, what do you have? Rest and oxygen. And get to nitrates. You need to get to help. Call doc, rapid response, charge nurse, whatever you need. You need to get to them through their nitrates. And then you probably, instead of calling EMS if you're in the hospital, you're going to be calling the doc or calling Who else? You're gonna get help after that first nitrate. Because I don't know if it's stable or not, but I'd rather have my help on the way in case it's not stable. If it goes away after that first nitrate, I can send people back and just be like, you know what, hey, I gave them nitrates, it went away, but hey, do you want to do anything else? Because I'm notifying. Chest pain, something we don't really want to mess with. So if no pain relief in 5 minutes, call EMS, or just go ahead after that first nitrate and get some extra help, okay? So if there's pain relief, they can repeat every 5 minutes for a maximum of 3 doses. If that pain returns at any point after the 3 doses, they need to go. So if they don't want to go, if they're like, no, this happens to me all the time. I just need pop a couple pills and I'll be okay. Okay, you can sit with them and keep an eye on them, but they certainly shouldn't be getting up and walking around or whatever. They can pop 3 nitro pills before, you're done. You're done. You're having a heart attack. Okay? So there is a little window in there where we're trying to assess whether this is stable or unstable. But 3 nitros, no chest pain relief, boom, you've just moved to heart attack. Unstable, angina. So you get 3 doses, but I myself would not wait for 3 doses of nitro. I would probably ramp up for help before then. Okay? So sit them down, rest them, oxygen, nitrates. So let's say we've moved on beyond that, and yes, now we are at, and some patients, they may be on nitroglycerin patches at home. They have such bad angina. They have angina when they cross the room. They're very unstable. The only thing keeping them stable is a constant infusion of nitrates. That patient's teetering on the brink really close. This patient's very, very risky for having that heart attack. So these long-term, if you see a patient or they tell you that they have these patches or pastes on, that is a patient that you definitely want to monitor. That means they have such chronic, stable angina that it can't be maintained without a constant infusion of nitrates. That's almost borderline for a heart attack. And we'll see this on people after heart attacks because we're just trying to keep their coronaries open. But if they're doing it to maintain their chest pain, they're very tenuous. And they're at very high risk for having that heart attack.
Why would a doctor do that? It feels like they're blanketing the...
Maybe they're refusing treatment. Maybe they don't want to go into the hospital. Maybe they don't want an intervention. I don't know. People do it. Most of the time we see these long-term nitrates after a heart attack because it'll keep the coronaries open. But just in case you see someone who's got a nitro patch on, your first instinct is going to be like, they're probably having an MI. Because a couple of nitro pills aren't going to help if they're already taking they already got a nitro patch on. So just to keep it, just to have an ID. So let's say we've done oxygen or we've rested them and given them their nitrates. No go. Now we've moved into heart attack. Okay. Heart attack is acute coronary syndrome, unstable angina, heart attack, MI, whatever you want to call it. All the same words. Synonyms. They're all the same words. So still pain. Same kind of pain, same places, but unresponsive to nitrates, or nitrates only work briefly and then it goes away. Pain is not better with rest. Unstable angina, heart attack. They have a heart attack. Now, this is most patients with heart attacks. What does this look like to you? If they're having increased heart rate and blood pressure and then dropping a heart rate, they're having crackles. They're having crackles in their lungs. They have fluid buildup on their neck. They're having abnormal heart sounds. What do you think is happening to their heart? They're going into heart failure. I am hoping that your heart attack patients are not going into heart failure right away. I'm hoping that your heart attack patients have some time before they go into heart failure. So that is not a guarantee that you're going to see those things with a heart attack. But what is a stressed heart going to do? Is it going to slow down or speed up? It's going to speed up. Because what's telling it to speed up? That sympathetic system is like, dude, hello, I'm not getting anything. Speed up. Work harder, work faster. And it's like, okay, work harder, work faster, but it's dying. It's not a very good system if the heart goes bad. So anyway, we have an acute heart attack. We are having a heart attack. So they may have these cardiovascular symptoms, they may not. but usually a stressed heart will speed up. This person's heart could be up because they're anxious. But you may see an increased heart rate, you may see a decrease in blood pressure, you may see increased. I don't know what you're gonna see. All I know is you're seeing consistent chest pain that's not going away. You may see nausea and vomiting. It depends on where in the heart is being, having a heart attack. This is because of vagal stimulation. We have the vagus nerve goes to the heart, and if that is being stimulated, you get nausea and vomiting, and that's one kind of heart attack. It's not every heart attack has nausea, vomiting, but some of them do. So you may see weird heart stuff, you may see crackles, you may see nausea, vomiting, you may see a fever. And you're like, which ones? I don't know. But you have, as a whole, everybody having a heart attack will have chest pain that does not go away. So we've decided that they have a chest, this is what's going on in the heart. This is just I like my picture with my finger better. This is your finger on no scrunchie. This is your finger with scrunchie for a while. This is your finger with scrunchie for a couple hours. Okay? It's just progressive damage. Not too worried about those right now. So, here is so Mona's up there, but that's not the right order. What's the right order? ONAM is the right order. And I think I don't know if I have ONAM on another slide. ONAM is probably the one you want to remember, but it doesn't sound as good as Mona. But ONAM is the correct order. Oxygen, nitrates, aspirin, and morphine. So your patient is having unstable chest pain. Well, hopefully you were with that patient during stable chest pain and already did the oxygen and nitrates. You were already in that process. You've already done that. And you've decided, we're not here, we're unstable, so now you can add aspirin and morphine.
Do they add heparin to that too?
Not that I know of.
Medical heparin in the blood?
Not without a doctor. No, this is stuff we can do, and most hospitals have this. EMS has this as their protocol, right? Hospitals have this as a protocol as well. All right? That you don't have to get a hold of a doctor to get these things. You may have, I don't know if EMS has heparin or not. Do they? Yeah, I don't know. And on hospital chest pain protocols, they do not have heparin. Chest pain protocols go ONAM. And chest pain protocols are there as standing orders for you. Like basically, I have a patient that has no history, they have no orders for this, but I can still get this because it's important that they have it. Okay? So you will always, if your patient is having chest pain somewhere, find out from your hospital, chest pain protocol, and I guarantee you they will have something for chest pain patients. That you can get to these things quickly. You can override them, you can get your charge nurse to get them, you can get these things for your patient because it is the first treatment, is ONAM. So you will always be able to put oxygen on your patient without getting in trouble. You'll always be able to give nitrates to your patient without getting in trouble. You'll always be able to give them their aspirin and their morphine without getting in trouble. After that, then the doc has to be involved in all the other therapies. Heparin is a good idea, but it is not, there's very high risk and we don't want people giving it in a stressful situation. So these are your 4 and what you're going to do for chest pain is ONAM. The other thing that you're going to do is if you are in the hospital or once EMS arrives, 12 lead EKG and continuous monitoring. We want to get a picture of what's going on as soon as we can. So if you're sitting with someone on the street and you've rested them and you're giving them their nitrates, you called EMS after that first nitrate. EMS shows up and they're like, yeah, it's not better. By the time EMS shows up, you've given them their second nitrate. And they're like, yeah, this is unstable angina. What is EMS going to do? They're probably going to throw on the aspirin, the morphine, and do a 12-lead EKG and put them on a heart monitor. Because that is the next steps. And so if you have EMS, that's what they're going to do. But in the hospital, your patient comes to you and they're taking a walk and they're like, I'm having chest pain. And you're like, oh God, no, don't have chest pain. Oh, please don't have chest pain. Okay, take a breath yourself. Breathe for yourself so you can breathe for your patient. Sit them down. Ask them if it's getting better. See if someone can get you some oxygen. See if someone can get you some nitrates. You know, get the chest pain protocol going. Get the 4 things for your patient. And then if someone arrives, you can ask for 12 lead EKG and cardiac monitoring. Those things are standard. EMS has them available to you. Every hospital has them available to you as well. Because we don't want chest pain patients waiting for the doc to call back. We want these things happening right away. So that is the order, and that is what we're doing for chest pain.
What do you mean by continuous monitoring? You're staying with that patient at all
Yes.
times?
Yes. Or someone is. You don't have to, but someone has to. Someone has to be watching this patient. Continuous monitoring means putting them on a cardiac monitor, whether it's portable or not. You may not have that capability. If you do not have them monitored, have someone stay with them while somebody goes to get stuff. This is a patient that is unstable. You don't get to leave them. They're in ABC. You have to make sure that they are still breathing, they are still heart beating, that everything's doing okay. They are unstable, they need treatment right away. Chest pain, unstable chest pain is an emergency.
One more question. So you know how in the hospitals, like right now we're in surgery and they put those monitors and then they call that room?
The telemetry room?
Yeah, so would that be considered a continuous
Yes.
monitoring?
Yes. So let's stay with, someone else might have the question. She asked if you're in the hospital and you put them on the portable pack and you have the other room watching them, is that considered continuous monitoring? Yes, it is. Because someone is watching, but they're only monitoring their heart rhythm. They're not monitoring the patient and how well they're breathing or responding. I would not, on an unstable chest pain patient, leave them alone in a room. I would differ. If you need to go get help, then get it from inside the room. Hospitals are set up that you can get it from inside the room. You push a button. Even if your patient's not coding, you can always hit a code button to get help. Code teams love to turn around and go away. They don't like not being called on time. So if you need help, you can call out. Most nurses are carrying phones now. You can call out to your charge nurse and say, I need some help in here. I'm having unstable chest pain. I need some things. So don't leave your patient. Stay with them. Get help from somewhere or scream out, I need help in here. Believe me, if you're ever walking around a hospital hall and somebody screams out, I need help in here, 10 people will run into that room.
Stupid question, the morphine and the wasting aspect, is that not even accounted for because of this?
Oh, you'll still have to waste it, so you're gonna need help.
Okay.
Morphine, you can't leave your patient to go to the Omnicell.
Yes.
I'm not gonna leave my patient, they're having unstable chest pain. They could drop at any moment. Go ask somebody else to get that for you and prepare it. You're also gonna be doing this. Your patient's having chest pain. You don't wanna deal with this today. So you need to be with your patient breathing. Send someone else to go get the ONAM, okay? Send for help, ask for help. If you're not at a hospital where you can't ask for help, get EMS. Okay? Any questions? ONAM, ACS, ONAM. After ONAM, when help has arrived, the best treatment is to go and get those blockages taken care of. They have to go to the cath lab. I mean, if a cardiologist comes in and overrides that, that's fine. Cardiologists can do whatever they please. But unstable chest pain should go to the cath lab. If you're out in the hospital and EMS comes, picks them up, they're going to take them to a hospital where they have a cath lab available. Because that's where you go next after ONAM is to the cath lab. Because the EKG and the continuous monitoring you've already done. So the next step is cath lab. When they go to cath lab, they can go in and do a whole bunch of different things. They can go in there with these catheters. These catheters go in through the femoral artery, sometimes through the brachial artery. And they actually thread a wire with a camera on the end of it into your coronary artery. And on the ends of these things, they can load on all kinds of stuff. They got all kinds of toys they can put on the ends of these catheters. This is a balloon on the end of it. So sometimes they just go in there, and this is not a gentle procedure. They are jamming something into a tiny coronary artery and trying to get past plaque. Almost looks like, calcification from your shower head. All right, this is not easy to get past. This is not gooey jelly stuff. This is hard stuff. So they're taking this thing and they're like knocking through there and trying to get through there. And then they take it in there and then they blow up a balloon and trying to squish it back against the wall. They can put this stent, which is this metal thing that they leave in place to basically
Create.
strut the vessel open. They have little roto blades on the end of them. And then they actually like roto-rooter with a little vacuum on it. And they basically roto-rooter it and vacuum up at the same time.
I wanna see
But-
one now.
Yeah, no, cath labs are amazing, amazing. They can do a lot of stuff. That's the only treatment is to get in there and open those vessels. If they get in there and they look at the vessels and they're like, we can't even attach, there's too many of them, they go straight to surgery for bypass surgery. So a heart attack's no joke. This is a picture of what it looks like before and after. It is amazing to watch, to be in the cath lab and watch that open up. I had tears in my eyes one day watching it because we were down there on a code. This patient was coding. We're down there doing resuscitation. It looks not even like this. It was like empty. And the patient was coding, arresting. We're over there doing CPR and the surgeon's in there because of course he's still trying to open it. The only thing that's going to save it is opening this vessel. And he's getting angry and everybody's tense and we're coding this patient and then you see the blood flow. And you're like, oh, the patient's still coding, but everybody had a moment where they're like, oh, it was amazing. I think the cath lab is amazing. But anyway, once this blood flow returns, now we've ripped off the rubber band. Now we wait and see how much damage had been done. So anyway, amazing, amazing, amazing. I love cardiac. I will turn you into